Hey guys! Today we're going to go over the glycogen storage diseases. The goal of this review is to provide you with both the memory tricks that'll help you perform well on your exams and an intuitive understanding of these diseases that'll help you make the diagnosis and maybe even feel comfortable managing it in the future. Step 1 is to review how glycogen breaks down into usable glucose. Step 2 will be to go through each of the 6 most common glycogen storage diseases and identify them as the result of a particular part of glycogen breakdown that is broken. Step 3 will be to do a rapid review with a couple of hopefully useful memory tricks, and we'll wrap up with one practice case and an interview with a patient. To start out, here's glycogen. Glycogen is a tree with a trunk and branches. There are 3 main enzymes that contribute to the process of breaking down glycogen into usable glucose. The first is Glycogenphosphorylase, which is essentially a saw acting at the alpha-1,4 binding site between each glucose, and it cuts off the bulk of the branches via a simple transfer of a phosphate group, releasing one G1P at a time. It continues along the branch until it hits its limit at 4 glucoses, aka limit dextrin, remaining on that branch. This is where debranching enzyme steps in, which has both gluconotransferase and glucosidase activity, transferring the 3 most distal glucoses to the end of another branch with gluconotransferase, and trimming the last glucose off the side of the trunk with glucosidase, with the latter being more relevant in the context of disease, which is why we'll refer to this enzyme as either debranching enzyme or alpha-1,6 glucosidase. If this breakdown process is happening in the liver, which is the primary storage site for glycogen, we now have a bunch of free G1P that is converted to G6P, but remains trapped in the cells of the liver until that phosphate group can be cleaved by glucose 6-phosphatase. Once that phosphate is gone, the glucose is no longer a prisoner to the cell and can float freely through the bloodstream to whatever organs and tissues need it for energy. Of course, this assumes that we have working glucose 6-phosphatase. If we don't, we have type 1 glycogen storage disease or von Guericke disease. The association between the numbered type and given name of these diseases can be confusing, but we'll try to solidify those associations as part of our rapid review later on. Type 1 GSD really stinks because it's a roadblock not only at the end of glycogenolysis, as we just discussed, but also at the end of gluconeogenesis, meaning that none of your stored or newly created glucose can escape its phosphate prison and enter the bloodstream. Recognizing that this is the point in the process where glycogen breakdown is broken is the first step towards intuiting its effects on a person. So, rather than telling you the clinical presentation of type 1 GSD, I'll ask you, where is there too much glucose? And where is there not enough glucose? You can pause to reflect on your own and hit play when you're ready. Because glucose 6-phosphatase is the broken or deficient enzyme, we get a backup of unusable phosphorylated glucose and the stored form glycogen in the liver, leading to hepatomegaly, and in the kidneys, which are ancillary storage sites for glycogen, leading to renomegaly. On the other side of the roadblock, there's not enough glucose in the bloodstream because it's trapped, leading to severe fasting hypoglycemia and all of its no-fun side effects like nausea and vomiting, maybe seizure, and certainly weakness. People with type 1 GSD are likely to present with failure to thrive, as would be true for anyone with insufficient energy for anabolic processes. The other physiologic consequences are a little trickier to intuit because they require you to think back to biochem and remember the Cori cycle. Using the Cori cycle, you typically get to convert lactate produced by your muscles back into usable glucose through gluconeogenesis. But since type 1 GSD is missing the phosphatase that is also at the end of gluconeogenesis, we end up with a surplus of lactic acid, adding insult to injury by causing joint pain and soreness. Plus, the buildup of lactic acid causes a traffic jam along its excretion path through the kidneys, meaning other metabolic byproducts trying to take that exit, like uric acid, also get backed up, causing gout, which is another reason why type 1 GSD really stinks. So, how do you help your patients with von Guericke? Well, we established that there's too much glycogen stored in the liver and kidneys, so avoid fructose and galactose, which both get metabolized to G6P and would just contribute to the backup. We also noted that there's not enough glucose in the bloodstream, so you can help with that by suggesting that your patients consume frequent glucose and cornstarch as a steady supply of immediately accessible energy absorbed directly into the bloodstream from the gut. Beyond the Cori cycle being part of the consequences of having type 1 GSD, it's also the name of another GSD, type 3, or Cori disease. In Cori disease, the broken or deficient enzyme is one step back along the process of glycogen breakdown at the level of debranching. We also previously referred to debranching enzyme as alpha-1,6 glucosidase. Since the absence of this enzyme only affects glycogenolysis and not gluconeogenesis, the Cori cycle is left intact in Cori disease. It essentially ends up presenting as a milder form of von Guericke, where lactic acidosis and gout are not an issue. The buildup of glycogen is also still present, but not as big of an issue because you're still able to get some breakdown via glycogenphosphorylase. This leaves you with a bunch of limit dextrins that accumulate in the cytosol of glycogen-storing cells, in other words, too much in the liver, again causing hepatomegaly, and not enough in the bloodstream, again causing hypoglycemia. One super fun fact about Cori disease is that the hepatomegaly typically improves with age and usually resolves after puberty. According to a 2010 article in Nature, this may be related to a reduced relative glucose requirement. Kind of cool. You may have noticed that we skipped type 2, and that's okay. Let's just back up one more step in the glycogen breakdown process to talk about types 5 and 6 first before revisiting 2 and 4. So, back at the top of the glycogen breakdown chain, we have glycogenphosphorylase, which is interesting because it exists in a couple of notable isozymes. For our purposes, one specific to muscle and one to liver in hepatic cells. Muscle glycogen phosphorylase, or simply myophosphorylase, is absent in type 5 or McArdle disease. Hepatic glycogen phosphorylase is absent in type 6 or HERS disease. Myophosphorylase, McArdle. Hepatic phosphorylase, HERS. When myophosphorylase is deficient, you cannot use the glycogen stored in your muscles. You end up using whatever free glucose is available nearby, and then with prolonged use, you get really tired. Your muscles are devoid of a major source of energy and have to rely on either the conversion of lipids or amino acids as fuel. Your body may even use the muscle itself as a protein source until more glucose can be delivered from extramuscular storage sites. This eventual delivery of fuel in some form or another is responsible for the second wind phenomenon, which is where people with McArdle disease literally get a second wind after enduring that initial steep drop in energy level. The bummer is that using your own muscle as a protein source is rhabdomyolysis, which is bad because it releases myoglobin, an oxygen storage unit native to skeletal muscle, into the bloodstream, which is nephrotoxic and can lead to acute renal failure. Patients will describe cramping and dark urine, myoglobinuria, after exercise, which is an emergency. The extreme localized muscle breakdown is also concerning for potential compartment syndrome due to the enormous amount of swelling that can occur. Diagnosis of rhabdomyolysis is most often made via measurement of serum CK, creatine kinase, with a CK over 1,000 being concerning. The hallmark of McArdle disease, aside from confirmatory biopsies that show absolutely no phosphorylase in the muscle, is a low venous lactate, when you would expect it to rise with exercise. The reason for this is fortunately intuitive, given that lactate is generated from pyruvate, which is the end product of glycolysis, and McArdle's patients are not doing a whole lot of glycolysis without accessible glucose. Therefore, low lactate. If your patient is complaining of exercise intolerance with subsequent dark urine, and you find both high CK and low venous lactate in the context of otherwise normal markers of exercise, like an expected rise in ammonia, you should suspect type 5 GSD. Treat it with exercise precautions like consuming glucose in advance so patients have sufficient circulating energy that is not their own muscles, and hydrating to protect those kidneys. With type 6, HERS disease, we're back to talking about a glycogen breakdown issue in the hepatocytes, and are therefore going to see a lot of the same issues we already recognized as being typical of type 1 or 3, given too much glycogen in the liver, hepatomegaly, and not enough glucose in the bloodstream, fasting hypoglycemia. Treat it accordingly with starch. Another super fun fact, this time about HERS disease, is that it's the only GSD we'll discuss today that is X-linked recessive rather than autosomal recessive, so it should actually be called his disease. Now we can go back to the two GSDs we skipped, and they'll be relatively quick. Type 4, Anderson disease, is a problem not with glycogen breakdown, but with glycogen production, which is still a storage issue. The glycogen cannot be stored efficiently because the deficient enzyme in type 4 is branching enzyme, not debranching, branching. So you end up with long trunks of glycogen, not trees, trunks, which are poorly soluble and draw water into the cell. This affects all of the surrounding cells too, and we see hugely elevated transaminases, indicative of liver failure, with either liver transplant or death typically occurring before age 5. Treatment is primarily symptomatic. Type 2, Pompe disease, is a favorite among test makers. The deficient enzyme called acid maltase is present only in lysosomes and has both alpha-1,4 and alpha-1,6 glucosidase activity. It still breaks glycogen down into usable glucose, just in the lysosomes rather than in cytosol. This is a minor pathway, but lysosomes are present basically everywhere, so you get a buildup of intralysosomal glycogen in a ton of tissues: liver, muscle, heart, and nerves. Patients with Pompe's have a huge liver, a huge tongue, glossomegaly from buildup in this large muscle, a huge heart, cardiomegaly, and affected nerves leading to depressed reflexes, like a depressed swallow reflex in infancy, and general hypotonia. The excellent news about Pompe disease is that it was recommended for inclusion in the newborn screen by the U.S. Secretary of HHS in 2015 and is treatable with enzyme therapy. And there you have it, the top 6 glycogen storage diseases by number, name, deficient enzyme, consequences, and treatment. Here's a rapid review. This is a visual reminder of all the places where glycogen storage can go wrong, organized by GSD type from left to right, with a slice of muscle overlaying the liver. Notice that the odd-numbered types, and 6, pertain to those 3 key enzymes we noted in the beginning of this review as being essential to glycogen breakdown, and work backwards along the chain of events from the freeing of glucose with glucose 6-phosphatase, to the removal of limit dextrin with debranching enzyme, to the cleaving of alpha-1,6 bonds in myocytes and hepatocytes with phosphorylase. If you can remember the names of the enzymes that work on each of these steps, you can remember the associated GSD type. Type 2 occurs at a secondary site of glycogenolysis in the lysosome, and type 4 is an issue with the formation of glycogen rather than the breakdown. Now your only job is to pair the type to the name, which can be accomplished with a rhyming mnemonic of things you might find at Disneyland. Very pink cats and Mickey hats. Very Von Gierk, pink Pompe, cat Corey and Anderson, Mickey McArdle, hats hers. It's silly, but you'll remember it. And from there, the downstream consequences of any given enzyme deficiency should follow because you know what part of the pathway is affected. Type 1, too much glycogen in the liver and kidneys, hepatomegaly and renomegaly, not enough glucose in the blood, fasting hypoglycemia, a roadblock at the end of gluconeogenesis, which means a broken Cori cycle, leading to lots of lactic acid and lots of uric acid, gout. Type 3, basically a mild type 1. Cori cycle is intact because gluconeogenesis is intact, so none of the lactic acid or uric acid issues. Type 5, muscles can't use their glycogen stores. Exercise requires alternative forms of energy like lipids, amino acids, or your own muscle. Delivery of alternatives leads to a second wind, but rhabdo causes kidney damage, electrolyte disturbances, maybe compartment syndrome. Low lactate due to low glycolysis. Type 6, same enzyme as type 5, but in the liver. Similar presentation to type 3, but HER's disease should be called his disease because it's the only X-linked recessive GSD with all the others being autosomal recessive. Type 4, inefficient formation of glycogen, leading to poorly soluble trunks and poor outcomes. Type 2, lysosomes are everywhere. Huge liver, huge tongue, huge heart, and nerve issues causing hypotonia. Treatable with enzyme therapy. Let's wrap it up with a practice case. Your patient is a 15-year-old male with no significant past medical history. He complains of extreme fatigue at the beginning of every baseball practice and was concerned by the dark color of his urine after a workout left him with extreme lower back pain. You decide to admit him. What further workup do you want to do first? You can pause the video to think. If you included serum CK in your initial workup, you are correct. Dark urine is concerning for myoglobinuria as a result of rhabdomyolysis. If you also wanted to look for a flat venous lactate curve with normal rise in ammonia during exercise, you are double right. The serum CK comes back at 20,000 plus, and you are concerned for which type of glycogen storage disease. If you said GSD Type 5 or McArdle Disease, you are correct and have just diagnosed my younger brother, Alex Sheely.
Hi guys, how's it going? My name's Alex Sheely, and I was diagnosed at the age 13 with the rare glycogen storage disorder, McArdle Disease. So I never actually realized I had that disease growing up. I always just thought maybe I was out of shape or just fatigued a little easier than everyone else. But there was one moment in particular that I really remember noticing that something was wrong. Playing baseball, I hit a ball super far, no fence, and so I was just running the bases, running inside the park, home run, and going down the third base line towards home. I was practically walking at the end and collapsed on that home plate, just pure exhaustion. And in that moment, I knew something was up, but couldn't quite figure out what it was, and it wasn't until I was 13 when I was officially diagnosed. And so that actually came from me working out with one of those hand grasp exercise equipment pieces. And so I just did that. I kept using this arm over and over, squeezing it, working on the forearms, and I actually put myself into a state of rhabdomyolysis where my forearm just swelled up to the size of Popeye, and very soon after I was admitted into the hospital. I spent roughly probably 3 days there. Doctors had me on all sorts of IVs, getting fluids. That was how to keep my CK values down. And I just remember in that moment being like, wow, there's actually something wrong. And so it took a whole bunch of med students coming in, looking and seeing what was going on, and just a bunch of curious people to finally figure out that it was this rare disease, McArdle's. I don't particularly remember going through too many tests. I know that there was a few base kind of endurance exercises that I did. Other than that, though, unfortunately, there's really nothing to do to take care of McArdle's in terms of medications or any sort of cure. And I remember specifically the doctors telling me to avoid heavy lifting, more so that immediate energy stores, and wanted me to focus on endurance. I kind of didn't listen and was like, you know what, I'm going to college, I'm going to work out, get strong. And I found that through very careful heavyweight exercise training mixed with endurance that I could actually find a pseudo cure, so to speak, which would be just making sure that my body is in shape and healthy to where those everyday exercises, walking upstairs, lifting things, don't affect me as much. So while it's not necessarily me being any better, my muscles are just more attuned to exercise, so it helps me in the long run. So I'm doing pretty well. Since then, I have only been admitted into the hospital 3 times, once for the forearm and then twice for my lower back. The worst time in particular was when I did end up going to college and working out at the gym there with a buddy. I went squatting for the first time in a long time and actually got stuck under the squat rack, which just the being stuck under that and using those muscles mixed with the panic caused my lower back just to flare up super hard and basically started squeezing my lower spine. I hadn't experienced any pain like that in my life and ended up spending 4 or 5 days in the hospital. After that, I urinated the darkest colored liquid I think possible. I always describe it as pretty much black, and I thought I was gonna maybe die, honestly, and it was crazy. But I took that as another learning lesson, just to, while exercise is good, not jump into things, not necessarily just being careful. Always drinking water beforehand, eating beforehand, just doing things at my own pace, I've found has been the best way to combat my condition. My sister asked me how I describe my condition to people, and I told her that I don't, because seeing me on the streets or in general, you would never think that I had anything going on. However, there are moments in my life, whether it be hiking or just randomly walking uphill sometimes, a little fatigue, I've had to tell people, you know what, hey, I have this thing where I just kind of get a little tired. Could we slow down? But then there are those bigger moments where I actually hurt myself, or it's a little more serious, where I've had to kind of just go and say, yeah, I have this condition where if I overwork a certain muscle group, it can go into a state of basically swelling up is the term I use, and my muscle can harden, constricting blood flow, which can cause all sorts of issues and mad struggles for my kidneys. So that's how I kind of describe my condition to other people. But affecting me to this day, through all that learning, growing up, and through testing myself, working out, I've found this balance with a healthy lifestyle and working out that has allowed me to not be in the hospital for the last 4 or 5 years, and I plan to keep it that way. Thank you so much.
Thank you so much to Alec for sharing his experience with McArdle disease. I know metabolic disorders take a lot of effort to learn and review, but I hope this review makes it a bit easier and allows you to someday be the one who makes the diagnosis.